Good morning, everyone, and welcome to the latest installment in our Roadmap to Wellness webinar series. I'm George Casey with the Vasculitis Foundation, and today it's my pleasure to introduce and to invite Dr. Tanaz Kermani to join us. Dr. Kermani is an assistant clinical professor at the Division of Rheumatology at UCLA. She had a rheumatology fellowship at the Mayo Clinic and dedicated an additional 2 years as a vasculitis fellow through the Vasculitis Clinical Research Consortium Fellowship at Mayo. She's done research in giant cell arteritis and Takayasu's arteritis and has several publications. She's now a clinician educator at UCLA and sees patients full-time, including referrals for vasculitis. Today she'll be talking to us about medications, the good, the bad, and the ugly. During our webinar, we'll have participants in listen-only mode, but if you have questions for Dr. Kermani at the end, we will try to address as many as possible. Just add them through the chat window in your GoToWebinar panel. So with that, I will hand it over to Dr. Kermani.
Thank you, George. Hello, everyone. Thank you for joining. I'm very happy to be part of this webinar series. And my topic for today is medications, the good, the bad, and the ugly. So I have no disclosures. And what I thought I would do is provide an overview about the general treatments that the general principles that we use to treat vasculitis. And then we're going to discuss only the most commonly prescribed medications, just in the interest of time. So these are the ones that we're going to discuss, the ones you see listed there. There might be others that you're on for treatment of vasculitis, which is not on this list here. So as you know, vasculitis is actually really a group of conditions that are autoimmune, so from the immune system misdirecting attention toward the blood vessels in the body. And this immune reaction to the blood vessels causes what we call inflammation. For the most part, we don't know the causes for forms of vasculitis, except for very few that we know are triggered by medications or infection, and those are actually treated a little differently. This inflammation from the immune system attacking the blood vessels can do damage to the blood vessels, or can also cause things like narrowing, where there's decreased blood supply, or then ballooning of some of the arteries. And I'll show you a slide with pictures on the next one. And because these blood vessels are supplying different parts of the body or different tissues and organs, you can imagine if there's been inflammation or damage to these vessels, the area that is being supplied doesn't get enough oxygen or blood flow, and that's what we call ischemia. And another concept to keep in mind is inflammation versus damage. So inflammation are things that we can actually direct with our treatment options, so they're active immune reaction to the blood vessels, whereas damage is a consequence of the active inflammation that has occurred. So damage is irreversible, and oftentimes that will not respond to treatment. So here's a schematic of the blood vessels and the different types of injury that can occur from vasculitis. So on the top panel, you can see a normal artery. So you can think of this as a pipe through which water is flowing, so like a garden hose. And if you have the normal lumen, which is the inside of the pipe or the artery wall, then you have circulation and blood flowing through there. Now imagine if, because of inflammation or mechanical reasons, you were to press that artery. So now you get narrowing, and so you can imagine, depending on the amount of narrowing, you'll get a different amount of flow coming through, but it's not going to be like the normal artery wall. So depending on how much that narrows, you can go all the way from narrowing, which is the second panel, or the B, and then all the way to complete blockage. And so you can imagine whatever is being supplied at the other end no longer has enough circulation. The other damage that can occur to the blood vessels is actually ballooning out of the blood vessels, or what we call aneurysms, and that's weakening of the walls where they form kind of sac-like areas that are bigger. And because of that, then you get turbulent flow, and you can either get clotting inside that wall, or in rare cases, those aneurysms can actually burst open or rupture. So because we don't know the cause for most of these forms of vasculitis, but we know that the immune system is overactive, what we do is we direct our treatment toward the immune system. So that's what we call immunosuppression, and that's what most of our medications are doing. And whenever we're treating people with vasculitis, there's always a few things that we want to achieve. The most important one is decreasing inflammation so that we don't end up with more damage either to the blood vessel or the organs that they're supplying. We want to achieve a state of what we call remission, so we would like to have no disease activity, but in some cases we'll settle for things like low disease activity. And then after we've achieved remission, we always want to keep people in remission to prevent what we call flares. So flares are active disease that comes back after a period of remission. For the most part, these are chronic diseases, so they can have their ups and downs in terms of activity. And then we always want to monitor for side effects of the treatments that we're giving. So things that influence what kind of treatment we use are what kind of vasculitis we're treating, and then also what areas are affected from vasculitis. Again, we want to make this a risk-benefit ratio. Some of the medicines we're using do have serious side effects, so we always want to keep that in mind. So things like skin disease, joint disease might be treated very differently from someone who has kidney disease or nerve involvement or had bleeding in their lungs. At the same time, skin disease just from a rash would be treated differently from if you had skin involvement where you were getting ulceration. So again, it's always kind of a risk-benefit ratio and seeing what areas are active, how serious they are in terms of how we tailor our treatment. And then other things can also influence our treatment decisions, including presence of other things like high blood pressure, diabetes, people with kidney involvement, or kidney dysfunction. Some of those factors also influence the drugs that we choose. So the general principles to keep in mind, because in a few slides I'm going to start listing some of these medications and their side effects, are that all of these medications require regular follow-up with the doctor. And there's two reasons. One is to make sure that they're doing what they're supposed to do and they're effective, and then also to monitor for side effects. A lot of these side effects, or at least some of the abnormalities with blood counts, liver function, which is side effects that are listed for almost all of these medications, are reversible if we're able to find it early enough and adjust things. So it's very important to follow up regularly. And then most of these medicines we're talking about months before they start working. So really, with the exception of prednisone, nothing else takes care of the inflammation right away, which is why you'll see that we use prednisone almost universally for all of our forms of vasculitis, because we don't have the luxury of waiting several months for some of these other medicines to work, because by then more damage is likely to occur. Like I said, regular blood tests are very important for monitoring for safety. Most of the abnormalities that we see with blood counts or liver function are reversible if we can detect it early enough with routine blood tests, pardon me, and then make necessary adjustments. And these medications in general are not safe for pregnancy or breastfeeding. So if there are any plans, those need to be addressed with the doctor to either make adjustments in the treatment or to discuss whether that's something to consider or not at that particular point in time. And same thing for men. Some of these can affect the fertility or the sperm count, usually temporarily. So that would also be a reason if there are any plans for children to discuss with the doctor first. So because they're all suppressing the immune system, they're also going to have side effects which are decreasing your body's ability to fight infections, which is what the role of a healthy immune system is. There isn't much you can do. There are sick people all around, but if you know someone is really sick, maybe avoiding sick contacts if possible, and then things like practicing good hand hygiene, hand washing can also help. If you have any signs of infection, always get seen right away to see if you need to be treated, because some of these medicines really do suppress the immune system quite a bit. And then we always advise being up to date with vaccines, but live vaccines may be contraindicated depending on the medications that you're on. So things like the shingles vaccine, flu mist, those are things that you would need to make sure with your doctor that they're okay to get. Most of them are not okay, apart from the flu shot is okay, pneumonia vaccine, those are okay. So starting off now with the medications. So the first one is prednisone. So these are in a group of what we call steroids, and we use them for almost all forms of vasculitis. They work very well, they're very fast-acting, and they can decrease inflammation right away. We have options to use them at very high doses through the vein, and followed by pill form or just pill form, depending on what areas are involved. However, as anyone who's taken prednisone knows, there are a lot of side effects. But in general, these side effects actually depend on the dose that you're taking and how long you're on treatment for. So the higher the doses or the longer you've been kept on steroids, we're talking about months to years, the more these side effects start to act up, or add up rather. And some of the common ones are things like an increase in appetite, weight gain, redistribution of fat so that people have this kind of round, puffy moon face, fluid retention. Some people get mood changes like irritability or depression or mania. Again, some of these things are more prominent at the higher doses, and for the most part, they start to improve as the doses come down. You can also get skin thinning, easy bruising. Important to follow up with an eye doctor if you're having any vision changes. Most people will report some blurry vision, especially at higher doses of prednisone, but it can also cause things like cataracts and glaucoma. And then, again, suppressing the immune system, so risk of infection. One of the long-term consequences are bone thinning, and that can occur very early on with the prednisone. So you can get either thinning out of the bones, which is osteopenia, or actual osteoporosis, where it increases risk for bone fractures. It can raise sugar or in some cases induce diabetes, high blood pressure, muscle weakness, and then the important one is never stopping this medication abruptly, because it's actually made by the adrenal glands, which sit above the kidneys. But when you're taking prednisone as a pill form, those glands don't really have to work to produce the prednisone because they're getting it from the outside. And so it's only safe to come down slowly on the prednisone, because in some cases those glands don't wake up. So never stop it abruptly. That can actually cause trouble with shock. So if you're having side effects, always discuss it with the doctor. Never adjust this medication by yourself, and certainly don't stop it abruptly. So the important thing is keeping in mind that the medication should be used as directed. So no increasing or decreasing on your own. Always do it under the supervision of your physician. The weight gain is very common, including increasing the appetite. So you can actually control some of that by watching your diet and trying to maintain a healthy weight, being active, exercising, so that you don't end up with a lot of weight gain. Because the bone thinning is actually a serious consequence, and it can happen really early on, and that's irreversible. We usually put people on calcium, vitamin D to protect the bone. And then sometimes we have to add other medications to reduce the risk of lung infections, something called pneumocystis, which can get reactivated in people who are on high doses of prednisone. So sometimes an antibiotic called Bactrim is added. That only helps with this particular infection. It doesn't treat all lung infections. So again, if you have any signs or symptoms of infection, you need to be seen. And sometimes we have to put people on treatment with osteoporosis type medications, because again, this can progress the longer you're on the steroids. You lose more bone mass, so that's not reversible. So we like to treat it early on before people start losing bone mass. And then again, important to keep in mind vaccinations, the flu season, getting your flu shot. But as for any live vaccines, check with your doctor. It depends on what dose of prednisone you're taking, whether that's allowed or not, so especially the shingles one. So the next drug I'm going to discuss is cyclophosphamide, or Cytoxan. So this is actually a chemotherapy drug, so used to treat certain forms of cancer. And we do use it in certain forms of vasculitis to put people into remission or to treat really bad flares. So this is one of our most potent immunosuppressive medications. So again, there are specific reasons why we put people on this medication. It's available either as through the vein or as a pill form that would be taken daily. The vein form is usually dosed every 3 to 4 weeks, depending on the regimen that's being used. We have to adjust the dose for people who have kidney dysfunction, and it's not safe for pregnancy or breastfeeding. So because it is a chemotherapy drug, common side effects do include things like nausea. We can treat that, vomiting, hair loss. It does affect the bone marrow so that you don't get enough production of white counts, platelets, or the hemoglobin as well. So again, that's something we have to monitor for closely. Sometimes can cause liver dysfunction. It's a very potent immunosuppressant, so it really does increase risk of infection quite a bit. And then in both men and women, it can cause loss of fertility, but there are some steps that we can take to help if we have to put people on these medications or on this medication. And then the other rare but serious side effects are things like a bladder hemorrhage, because it can irritate the lining of the bladder, and then increased risk of cancers, particularly bladder cancers and blood cancers. And there are studies that have shown that this can actually occur years and years later, so it may not be right after you receive the medication. And these are things that we monitor people for. But the cytoxin side effects are also kind of like the prednisone. It depends on how much you've gotten over the course of the year, so how many treatments and what doses. So some of these things do depend on that. And these days, we've learned how to use this medication for the shortest period of time that we need, and we reserve it for serious organ involvement. So very important, again, to have regular blood testing, especially blood counts. And people who are on the pill form, we might even check that every 1 to 2 weeks, because it can really suppress the bone marrow. We watch liver function. We always monitor the urine as well to make sure that there's no blood in the urine or irritation from this medication. Very important to stay well hydrated if you're on this medication. And if you're on the pill form, it's preferable to take it in the morning. Drink lots of water, and if you feel like you have to urinate, just go and urinate. Don't let the medication just sit around in the bladder. And then if you get any signs or symptoms of infections, so fevers, bad cough, feeling unwell, get seen right away. It does suppress your immune system. And if you see any blood in the urine, that needs to be brought to your doctor's attention right away. So moving on to methotrexate. This is also a drug used to treat certain forms of cancer or chemotherapy, but not at the doses that we use in rheumatology. And we have long-standing experience in rheumatology with methotrexate. It's our first line for treatment of rheumatoid arthritis, which is another autoimmune disease that can cause joint inflammation. So we're very familiar with this medication, and we've been using it safely for a long, long time. It is used as a first-line agent for some forms of vasculitis, or sometimes to keep people in remission. It's available as pill form, usually taken once a week, or an injection that you would give yourself once a week. Typical dose is somewhere around 20 to 25 milligrams once a week. We don't use it much in people with kidney dysfunction, depending on how much kidney involvement they have, because it might cause more side effects. And then in people who have liver dysfunction, we have to be a little careful, because again, as you'll see later in terms of the side effects, liver is one of the areas that can get involved or that can have trouble when you're on methotrexate. We've put people on folic acid. It's a vitamin that can actually help counteract some of the side effects of methotrexate. And this one, again, not safe for pregnancy or breastfeeding. So some of the side effects are things like hair thinning, sores in the mouth. Those we can usually adjust the folic acid level, which is the vitamin we put people who are taking methotrexate on, and that can help. It does cause some sun sensitivity, so sun protection is advisable when you're on this medication. Some people get an upset stomach. In severe cases, it can be things like diarrhea, nausea, vomiting. But again, some of these side effects, people can get used to over time, especially if we start at a low dose and work it up. But sometimes people are not able to tolerate it, in which case we would consider other medications. While you're on the medication, we have to monitor blood counts and liver function because, again, those can be affected by the methotrexate. But again, as long as you're getting your regular blood tests done, these are things that we can catch early enough, adjust the dose, and can use safely. In rare cases, it can cause something called pneumonitis, which is like an allergic reaction that happens in the lungs. So people would usually present with like a dry cough or suddenly feeling really short of breath or fevers. Most of the time we would still worry about infections first, but sometimes it can be a drug reaction that's occurring in the lungs. Again, as long as it's brought to the physician's attention, these are things we're familiar with, and it can be treated by just stopping the medication. In some cases, we may have to treat with steroids to help with the inflammation. Suppressing your immune system, so increased risk of infections. And then it can cause increased risk of lymphoma, which is a type of blood cancer. In the case of methotrexate, that tends to be because of reactivation of the mononucleosis virus, the Epstein-Barr virus. It's rare, and in some cases, actually just stopping the methotrexate caused regression or treatment of the lymphoma. In other cases, people may require treatment for lymphoma. So important things with this medication would be taking it with folic acid, avoiding alcohol if possible, because again, it can cause involvement or it can cause liver enzymes to go up. Again, very important to get your regular blood tests done. There is a drug-drug interaction with high doses of Bactrim or Septra, but not at the doses that we use for prophylaxis. So there are some people that we will put on methotrexate with Bactrim. And then, again, reporting any signs of infection for sure, but especially if you're getting any shortness of breath or having a dry cough, that might be signs of the lung involvement. And then if you notice any swollen glands, those would be things to bring to your doctor's attention because of things like the lymphoma, which can occur in rare cases. So the next medication is azathioprine or Imuran. Again, used in certain forms of vasculitis, either to put people into remission or to keep them in remission. It's only available, well, the way we use it in rheumatology, it's only available as a pill form for us. And we can use it in cases where there's kidney dysfunction as opposed to the methotrexate that we discussed before. We do a test oftentimes to see how people will metabolize the drug, so it's called a TPMT test. If people have problems or abnormal tests, they might have issues with how they metabolize the drug and might be at higher risk for things like blood count abnormalities. So in those cases, we might just adjust the dose or consider a different medication. If possible, we prefer avoiding in pregnancy, but that's not an absolute contraindication. But again, if you have any plans for pregnancy, this should be discussed with the physician who's treating you. So in rare cases, if the risks outweigh benefits, we might continue it in pregnancy. And it's not recommended for breastfeeding. So again, side effects like nausea, vomiting, loss of appetite. Some of these things, again, can be better tolerated if we start slowly and slowly build up the dose. It also affects your blood counts and liver function. So again, important to keep monitoring for those. It increases risk of infection. And then a lot of our medicines that are targeting the immune system now carry warnings for increased risk of cancer as well. And some of the reasons are we're learning more and more that the immune system is actually also important in surveilling, in looking out for cancers or fighting some forms of cancer as well. So for this one, skin cancer, other things like leukemia as well have been associated with this drug. It can cause pancreatitis, which is inflammation of the pancreas gland. So sometimes people can have really bad pain in the middle of the abdomen or nausea, vomiting with it. That should be seen right away or evaluated right away. In some cases, people get an allergic reaction to the drug where they can get a rash, stomach pain, fevers. And then again, keeping in mind drug-drug interactions, especially with allopurinol, which is a very common drug that's used for treatment of gout. So the two of them have a drug interaction where the allopurinol can result in higher levels of the Imuran, or the azathioprine rather, and that can actually lead to more problems with suppressing the bone marrow. So it's safe to use as long as the dose of Imuran is actually adjusted. Important things would be avoiding alcohol, getting your regular blood test, and then if you have fevers, rashes, stomach pain, nausea, get seen right away. And then remember the drug-drug interaction with allopurinol. So if you're on allopurinol or if you're on Imuran and get put on allopurinol, just something to remind your physicians of. So then we have Mycophenolate, Mofetil, or Cellcept. We use this to maintain remission in certain forms of vasculitis. It's also available as a pill form. This is one of the medications that's also used for kidney transplants, so it's safe to use for kidney dysfunction. Again, not safe for pregnancy or breastfeeding. So some of these should look familiar by now. So again, upset stomach, so nausea, vomiting, diarrhea. It can cause problems with the blood count or liver function abnormalities, which we monitor for with blood tests. Can cause problems with high blood pressure, ankle swelling. And then in addition to increased risk of infection, which all of these medications carry warnings for because, again, they're suppressing your immune system, it can also cause a rare condition called progressive multifocal leukoencephalopathy, or PML. What this is it's a virus called a JC virus that all of us were exposed to as children. And then the virus stays inactive in the body. And then in some cases with some of these immune suppressing medicines, the virus can reactivate and go to the brain and cause a rare condition. I'll talk to you about some of the signs and symptoms. Again, these are very, very rare. There are few cases reported for the number of people that we've treated for all of our rheumatologic conditions. And again, it's always a risk-benefit ratio. So we'll talk about the PML in a bit. And then also carries warning for increased risk of cancer. Again, the immune system does seem to have a role in looking out for cancers or fighting some early cancers in the body as well. So our immune suppressing medicines target both the good immune cells along with the ones that are causing mischief and vasculitis. So these are some of the consequences of suppressing the immune system. Very rare cases, stomach bleeding. In general, it's preferable to take this on an empty stomach to help with absorption, but if it's causing a lot of gastrointestinal side effects, sometimes I'll let people take it with food. Again, regular blood tests, and then some of the signs for that PML would be things like confusion, behavioral changes, difficulty walking or with balance or thinking. If we suspect it, what we would do is MRI and or get fluid from the spinal column to test for this virus, or in rare cases like a brain biopsy. So the Rituximab is the last one I'm discussing. This was recently FDA approved for treatment of certain forms of ankle vasculitis. We also use it for other forms of vasculitis. This is only available intravenously, so it's administered. There's two different ways we can do it. One is a dose that's given once a week for 4 weeks. The other is one dose given 2 weeks apart. This one doesn't seem to affect fertility, but we don't know about its safety for pregnancy or for breastfeeding. Also remember, this medication, the effects actually linger on for sometimes 6 months to a year in terms of the cells that it affects. So the infusion reactions, because it's going through the vein, some people can get muscle aches or low blood pressure, fever. These are things that we monitor for very closely. And so it has to be administered at a facility that is familiar with giving these infusions. It's also used for certain forms of blood cancer, so the hematologists sometimes are very familiar with administering this medication as well. So usually people would go in, the infusion's given very slowly, they're watched very closely. It can cause problems with low white count. This one also carries warnings for infections in general, but also that PML, like we discussed with the previous medication, the Mycophenolate, Mofetil. And if possible, it's preferable to get vaccines before you get put on medications like Rituximab or any of our immune suppressing medications, because it can actually reduce the effectiveness of the vaccine. But again, sometimes that's not practical. So what we do is usually give people pre-medications, so sometimes steroids through the vein or Tylenol or Benadryl to try and reduce the reaction to the medication. We monitor for infections, and then again, if you have any new neurologic symptoms, the confusion, difficulty thinking, walking, instability, those would be things to bring to your doctor's attention. Again, very, very rare reports of this PML occurring in people who have been treated for rheumatologic diagnoses with Rituximab. And keep in mind, some of these drugs are also used for other things. So some of the literature is also from side effects that were noted in people being treated for other conditions that are not vasculitis. So to summarize, always use these medications as directed under the supervision of your doctor. If you're having trouble with the medications or the side effects, just discuss things with the doctor. We can always make adjustments to see how we can ensure that the medication is better tolerated and also doing what it's supposed to do. Very important to get the recommended testing done regularly. Again, this can be months, years after you've been on the medication. It doesn't have to occur right away. So even if you've been taking the medication for a year or longer, some of these side effects can occur at any time. So it's very important to stay with the regular blood tests. Usually they're done every 2 to 3 months depending on the medication you're on. If you have any signs of infection, very important to get seen right away to make sure that you get the appropriate treatment. Discuss any plans for pregnancy with your doctor, and for men as well. If there are any plans for children, just discuss it with your doctor so that they can make any adjustments that they need to. And then there is only so much that you can do in terms of preventing infections, but staying away from sick contacts if possible, getting appropriate vaccinations, those are some things that can help. With that, I'll thank you for your attention, and I'm happy to take questions.
Well, that's great. I think that was an excellent kind of overview, and I think I'm realizing I'm feeling a little bit I regret that we didn't play medication bingo, because I think I would have had a good scorecard.
Yeah.
I think unfortunately we could have played side effect bingo too, and a lot of people on the call would have probably been able to get good cards there too. But speaking of side effects, I think we got a lot of good questions around some of the bad and the ugly of the diseases or the medications you described. So we have one question specifically around prednisone and the stomach effects, and asking for a little more details to what kind of stomach side effects do you see with prednisone?
Yeah, so usually it irritates the lining of the stomach, so we try and put people on antacids if they're going to take the really high doses in particular. In rare cases, if you've been taking something like Advil or Aleve on top of it, it can actually cause ulcers. But prednisone by itself typically doesn't cause ulcers, it just irritates the lining of the stomach. So symptoms would be things like bloating, upset stomach, pain on the left side in particular.
Okay, I think that's great. I think kind of along the side effects theme, some of the scarier side effects you talked about were some of the cancers, and you mentioned that with Cytoxan or cyclophosphamide. So in terms of what a patient can do that has been on cyclophosphamide, are there certain tests or things that a doctor should monitor to make sure that they understand kind of long-term how they're doing with what their risk looks like?
Yes. So that's a great question. So for the bladder cancers, sometimes what we'll do is something called a urine cytology once a year, so where they'll actually take a look and see if there are any atypical looking bladder cells under a microscope. So that's one of the ways we can monitor for bladder cancers, or just a regular urine to look and see if there's any blood that's developing in the urine that might not be detectable or visible. And then for the blood counts, the only thing we can, for the blood cancers, the only thing we can do is really monitor the blood counts periodically. Sometimes to protect from getting some of the bladder side effects, we put people on something called Mesna, especially if they're getting it through the veins, so that can actually protect the bladder. But apart from that, there really isn't much else that we can do.
Okay, so a less probably scary side effect, but one a lot of people have reported issues with or challenges is fatigue with some of these treatments, or just whether it's the damage or the treatment, it's hard to predict. So do you have suggestions that you would give to our audience around how can they alleviate that fatigue?
Yeah, so the fatigue part can be very challenging to treat. It can be both from the condition itself and also from the treatments that we're using. So usually if it's from medications like prednisone, that will typically get better as things are coming down or as the doses are coming down. If it's more from the condition or some of the medications that we have to keep people on for years, important things would be, getting enough sleep. Sometimes I tell my patients if they have to take a nap, they have to take a nap. And then it's very important actually to address any mood issues. So things like depression can also result in people feeling more fatigued. And then staying active. So regular exercise can help as well, both with the sleep and also with energy levels.
I think that's great advice. Along the lines of, especially with the prednisone, and you talked about some of the risk of bone thinning or the osteoporosis and osteopenia. With respect to the supplements and calcium and vitamin D, is there a general recommendation around dosage there?
Yeah, so typically for calcium around 1,200 to 1,500 milligrams. The vitamin D about 1,000 to 2,000 international units. But I always check vitamin D levels, and if people are very low, then they might need a stronger form of vitamin D that's prescription.
Okay, great. So in terms of, the other thing that I think you mentioned in some of these medications were more longer-term use, or longer-term, maybe we describe them as maintenance dosage. And so what's kind of the thinking in terms of, whether it's prednisone or methotrexate and the use of long-term maintenance doses to prevent relapse? Is that still kind of best practice? Does it vary case to case? I mean, what can you say about what people would consider with those?
So that probably will vary case to case. So, in general, if we can get people below 10, preferably somewhere around 5, probably not the worst thing. Your body makes about 5 to 7 milligrams of cortisone a day. So there's at present, we still say there's no safe dose of prednisone, but if it's something like 5 milligrams, that would probably be acceptable. But otherwise, sometimes we have to adjust some of the other medications or try different medications. But again, we want to weigh out the risks and benefits of some of these other treatments as well. So in general, if people are doing well, I'll try to get them off the prednisone, but if they're anxious or if I'm worried about it, I'll keep them on 5 milligrams.
Okay. And the other drug in terms of long-term use we got questions about was CellCept. So specifically, how does that affect kind of the patient's biome for continued use?
So there are people who have had, kidney transplants, heart transplants, where they're using it indefinitely. So that isn't. We don't really have a maximum amount of time that you can be treated with the CellCept. The main one that we worry about in terms of the number of doses you get over time is the Cytoxan and then the prednisone. Does that answer the question?
I think so. And I think, in terms of one of the advice I'd give to people who are still entering questions, it's great, and now's a good time to get your questions in. We're trying to keep these somewhat general, applying to the audience. It's hard to answer about specific cases, so just some advice as you're you're entering your questions. Specific questions around dosing and frequency. And so we had several kind of versions of this, but I think with respect to Rituxan, what are kind of some of the thoughts on different frequencies or kind of periods at which you'll continue to take Rituxan, and as it relates to just general dosing?
Yeah, so the Rituxan is a new one, so we're still actually trying to figure out how to administer it best. So there are people who are still investigating this. So, you know, do you just treat people periodically every 6 months? We don't know. Do you have to treat them with the 4 doses every single time? There are some studies that suggest just doing the 2 doses 2 weeks apart would be equivalent to the 1 every 4 weeks for 4 weeks. So we still don't have the answers about how best to use the Rituxan. We do know that the longer you get the Rituxan, over time some of the immunoglobulin levels in the blood, which are part of what helps you fight infections, do start to go down. So we would worry about increased risk of infection with that. But there are studies of at least 10 infusions or so, 10 cycles rather.
So that's a great kind of segue to another question around that kind of immunoglobulin levels and recommendations, or is there any kind of thinking around those bounce back therapies such as IVIG or such? You know, so someone asks a question really just kind of leading right up to your what you just described.
Yes. So I do monitor immunoglobulin levels. There's no standard recommendation about whether to do that or not. If people's immunoglobulin levels are low and they're having problems with infections, I actually have them see one of our allergy immunology colleagues to see whether they would be a candidate for IVIG.
Okay.
So I don't treat just immunoglobulin levels by themselves, but if that's actually translating into frequent infections, then definitely.
Okay, great. In terms of Rituxan, I think we have a few versions of questions around side effects there, but specifically around PML. And I guess can you remind us what that is and really help us understand kind of that risk?
Sure. So the risk is actually very, very small. The PML is something called progressive multifocal leukoencephalopathy. It's a tongue twister. It's a virus that all of us have been exposed to that kind of you never clear. It just lingers around in your body. And for the most part, when you have a healthy immune system, there's no problem. But when we do things like suppress the immune system with almost a lot of our medications, but definitely with Cellcept and Rituximab, that virus can get reactivated and cause infection in the brain. So those would be the symptoms that we were discussing. So, you know, difficulty with thinking or feeling like you have balance issues, tremulousness or tremors, things that are new. So if you feel like you have any of these symptoms, it's best to get evaluated. Most likely it's not going to be PML, but there are ways to test. The absolute risk is very, very small. So for the number of people that we've treated in general in rheumatology, we've seen most of this in people who actually have lupus, who have a very dysfunctional immune system to begin with. With vasculitis, the data is a little less, maybe also because these are such rare conditions, we haven't treated enough people with it, but so far very, very few reports. The last I saw was like 4 case reports for Rituxan in vasculitis with PML. So, you know, it's something we all worry about, but again, it's about the risks and benefit ratio. And so these are very, very rare side effects, so less than 1%.
So I think I think that's a great answer. Hopefully that addressed the multiple questions we got about PML and Rituxan. Regarding, you know, another side effect I think people have experienced and you identified with certain of these drugs is insomnia. Or challenge kind of maintaining sleep cycles. So are there recommendations for kind of maintaining healthy sleep patterns?
No. So I try things like melatonin supplements, but no, not otherwise. But just, you know, watching your caffeine intake, trying to put away electronic things, you know, phones, computers, those kind of things, so that when you're ready to go to sleep, you just go to sleep. And trying to get into healthy patterns. So, you know, bedtime, same time, all the time, consistently. So those are some of the things to try. And then exercise actually does help with sleep, so that's an important part. With a good cycle.
I think that's great. You know, I think one of our other challenges we face as patients is we see these drugs, you know, called by lots of different names, and I think that's challenging. So there's a question around Iburan, which I think you described in your presentation as Azathioprine, but can you kind of refresh us what the side effects are of that drug?
So for the Azathioprine, the main thing we worry about would be the counts and the liver function. Those are things that we monitor for. It does decrease your body's ability to fight infection. It can cause nausea, upset stomach, but again, usually if we start slowly on some of these medicines and kind of work your way up, people tolerate it well. And then it can cause rare things like something called pancreatitis, where it's inflammation of the pancreas. So that would be new stomach pain followed by nausea, vomiting. And then in very rare cases, it can actually cause an allergic reaction or what we call hypersensitivity. So that would be things like new stomach pain, fevers, rashes. So if you break out in a rash while you're on this medication and have stomach pain, definitely get evaluated. But those would be the main ones. And then increased risk of cancer has also been associated with the Azathioprine or Imuran, skin cancer, but also things like leukemias, lymphomas.
Okay, thank you for repeating. I think that's helpful, and it's helpful to us to kind of hear the different names. We might hear those kind of in the wild, whether we're talking with pharmacists or doctors.
And I'll put both of them. I should have done that, but I just go with the generic, which is what's recommended. But yes, I should have put the brand names there too.
So a question around, you know, vasculitis that's, you know, limited to skin, or when we see kind of different types of skin results, and not necessarily any daily medication, but in terms of for longer-term treatment, are there any things that we see around that type of vasculitis?
Yeah, so if it's isolated to the skin, or what we call leukocytoclastic vasculitis, and there's no involvement of any other organs, there are other options that we can do. Sometimes we do things like non-steroidals, so Advil, Aleve. Sometimes we'll use something called colchicine, which is actually a medicine we also use for treatment of gout. Then there's an antibiotic called Dapsone that's used sometimes, or some of these other medications that we discussed, so things like Methotrexate or Azathioprine, or the Mycophenolate or Cellcept. Or, again, it depends on how frequently it's occurring and how bothersome it is. But there are some other milder treatment forms that would be acceptable for people who have just skin involvement, as not part of one of the other forms of vasculitis that's affecting other organs.
Okay. Another drug you mentioned, I think, in not as a main heading, but during some of the other discussions, was Bactrim. And can you discuss some of that in terms of how we use it, or how it's used for treatment, or you know, side effect aspects or side effects profiles of that drug?
So the Bactrim we put, actually we recommend it for anyone who's being treated with heavy-duty immunosuppression. So things like the Cytoxan or really high doses of Prednisone, because we know that they can get a rare infection in the lung called pneumocystis. Now, for some conditions or some forms of vasculitis, like GPA or granulomatosis with polyangiitis, also known as Wegener's, people may also use it for the disease. So in that case, again, it's to help with some of the sinus symptoms. It does have a drug interaction with Bactrim, but with Methotrexate. But usually, if we watch the blood counts and liver function, that should be okay. Does that help?
I think so. And I think, you know, I think there's a question around a drug we didn't discuss, but a few questions around a drug that's, I think, is pronounced Xolair or Omalizumab. Do we see that use in vasculitis at all?
Which drug, sorry?
It's Xolair.
Xolair, oh, okay. So not much experience with rheumatology, but the allergy immunology people would be, have familiarity with it. It's probably, it probably has a role only for the EGPA or the Church-Strauss. It isn't used very commonly for the other forms of vasculitis.
Okay, and in terms of just some other side effect questions, you know, when we think about long-term prednisone, I don't think we discussed glaucoma as a side effect, but can you describe that? Is that something we should be paying attention to?
Yeah, so cataracts and glaucoma would be two of the side effects that we watch for with the prednisone. So that's about getting your eye exam regularly, and especially if you're having any vision trouble. And then if you're having bad trouble with glaucoma, they can try the drops, or you can have your, the physician may have to adjust the prednisone doses. But that's an important side effect in terms of vision changes that can occur with prednisone.
Okay, I think that's great. Now I would like to congratulate our audience. This is probably the most questions we've ever been able to do in a session like this, but I think we got to a broad sense of questions. If we didn't get to your specific question, we apologize. Sometimes you just have both kind of a timing issue as well as making sure it's appropriate in a forum like this, but we want to thank you for everyone who participated, and add a special thanks to Dr. Kermani for taking the time out this morning to spend with us and to educate us on obviously a very important part of our the treatment of these types of chronic diseases. So Dr. Kermani, thank you very much, and to the rest of you, thank you for joining. Pay attention to the Vasculitis Foundation website, and we'll be announcing both the next Road to Wellness webinar we'll be hosting, as well as provide slides and a video audio recording of the session we did today. So with that, I hope everyone has a great day, and we will stop the webinar.
Thank you, everyone.